The next topic is surgical management of the inter-implant femoral shaft fracture by Assistant Professor Saran Tantavisut from Chulalongkorn Hospital. Dr. Saran, please.
Thank you, Ajahn Prisha, and thank you, the section, to inviting me here. Okay, my topic is inter-implant femoral fracture. So this is the outline of the talk today. Okay. So what is the inter-implant femoral fractures? If we have a total hip up here, total knee down here, and you have fracture in between, we call that interprosthetic fracture. But if up top, down here, or both, or a fixation device, we call that inter-implant fracture. So the incidence rate of the interprosthetic is 5 to 7% of all periprosthetic fracture, while the inter-implant fracture rate is much lower. At this moment, we know that it's about just 0.3%. How to classify them? At this moment, not even agreement classification to classify this fracture. They suggest that we can use the classification that proposed for interprosthetic fracture and adapt to use with the inter-implant fracture. Are there any specific risk factor? There's still no specific data for the inter-implant fracture, but we can use the risk from the interprosthetic fracture. For the interprosthetic fractures, the point of concern is interprosthetic distance, the distance that I show in the picture here. If the distance is less than 110 millimeters, there are a study from Dr. Sonen and his team to show that it significantly increased the stress in this area and also increased the risk of the fracture. Lately, there are some argument from several authors, and they are not believe about this. So they pay more attention on the bone quality in the intermediate zone. If the intermediate zone here has low cortical thickness, wide intramedullary canal, and has severe osteoporosis, they believe that that is more contribute to the risk of the fracture. One thing that we should learn from this is not consensus yet about the risk, but what we can do, if we can, we should try to avoid kissing implant. What is kissing implant? It means two implants that come very close to each other. And if that's going to happen in your hand, you should go forward and add the bridge plate to reduce or eliminate the risk of future fracture in that patient. Okay, let's have a look at the case. In this case, the patient has total hip up top, and he has a fracture at the distal 1/3 of the shaft femur. Surgeon do the retrograde nail to fix it, and you can see that the intermediate zone is so small. The stress is concentrated highly in this area. So he go forward and add the plate to neutralize the force and prevent the future fracture. And if it occurs in your hand, what you should do to handle this rare type of fracture? So the principle is similar to periprosthetic fracture. So it depends on the location of the fracture, the stability of the implant, and the ability to achieve stable fixation. So the locking plate is the gold standard because it can be used in all types of fracture. You can have total hip, total knee. You can have any kind of instrument. The plate can get the way around these instruments. So it's a gold standard at this moment. And it can provide stability in osteoporotic bone. And you can use minimal invasive technique to preserve the biology for the fracture too. So the fixation must be achieved by any means possible. That means try to fix it as strong as possible. You have only small segment of virgin bone. You have this fracture in very osteoporotic patient. So if you can get bicortical screw, that is the strongest one. Try to get as much as you can. The VA plate would be an option, or like a plate attachment that would be your friend. So try to be prepared and make sure that you have enough fixation. You can use unicortical screw and tension circumferential clutch valve to elevate the level of stiffness of your construct. Or sometimes you can go on with the dual plate. If you think one plate is not enough and you have better chance of stronger fixation with dual plate, that is another option too. But you have to trade off with increased soft tissue dissection. And when you do it, try to have optimum plate span to prevent future fracture. You should have enough overlap of your plate of fixation with the current instrument. The overlaps should be twice the diameter of femoral shaft. That would be the recommended overlap span. Or if you don't sure how much you should go with the spanning, just span the whole femur. That is another way to do it. Okay, let's have a look at some case. This is my case. So the patient has bilateral PFNA on both sides for several years. She walked quite well, household ambulator. And she also has total knee down below. So she has a fracture like this. So we just have to make sure that there are no loosening of the prosthesis. And we can just try to reduce it and fix it with a minimal invasive plate. At 12 weeks, everything heals up nicely. You can use retrograde nail to fix this, but it's not very universal because it cannot be used in every case. If you're going to use a retrograde nail, you have to make sure that the instrument down below allow you to do the nail. Such as if you have TKA, you have to make sure that that design of the TKA has an open box in the optimum position to insert the nail. It cannot be used in the TKA with the stem extension. If the fracture occurs very close to the upper instrument, you cannot use this. If the fracture occurs very close to the lower instrument or very comminution, you cannot use it too. So there are some limitations to use this. In addition, if the fracture occurs very low, it's an increased chance of recurvatum when the fracture is completely fixed. And one last thing that is very important, if you go on with the retrograde nail, at the end of the case, you can create the new zone of fragility, new zone of highly stressed area, which might lead to new fracture in the future. So if you go for this, don't forget to maybe add some prophylaxis plate to prevent the further fracture. Revision arthroplasty is an option if you have a loose implant up top or down below. You have to make sure that it's not loose. Sometimes radiograph cannot determine everything. You have to go inside the intraoperative, do some stress test, push, pull the instrument, whatever, to make sure that it's stable. If it's stable, you can fix. If it's not, you should do the revision arthroplasty. This is my case. The fracture is pretty low, so I'm still uncertain that it's stable or not. So I go inside, try to do some stress test, and it's stable. It's stable, you just go on with fixation. This is a case from the literature. Fracture of the total hip is loose because it's subsidence. The surgeon go on with the revision. The patient also have TKA down below. So the intermediate distance is very borderline, so he just prevents it with the plate. The modular intermedullary metal sleeve, this is only for interprosthetic fracture, but I just want to show you that we have this kind of instrument too. In case that you have stable hip and knee, but you have compromised intermediate segment, you can use this sleeve to connect both instruments together. The result is just okay, not very well, but it's a salvage technique. In case that is very hopeless, you cannot just make the strong fixation. You fail so many times. Maybe this is the last resort, the total femoral prosthesis. Look at this case. failed fixation, the intermediate segment is very small. So in this case, surgeon go for the total femur prosthesis. How about the fracture? So we are orthopedic trauma surgeon, right? One unique features in the inter-implant fracture is sometimes you have to think about fracture condition. If it's healed, it's okay. Right? If it's healed, you can do whatever you want. You can remove fixation implant and then fix as need. If it's healed, you might keep the current fixation implant and put the plate on the side and try to get around the implant. Or you can modify the current instrument, such as you might remove some screws, so you have enough space to retrograde nail. So it depends on case. Like this is my case. So the fracture occur close to the TKA down below again. And the patient has the DHS up top. You have so many options because the fracture already healed. You can just reduce and put the plates on. You can remove some of the screws out, and you can do the retrograde nail. You can do whatever you want because the fracture up top is already healed. So in this case, I just go on with the reduction and fixation with the plate. With the instrument in the formula, there are hundreds of possible scenarios. Okay? So if the fracture is not healed, what you can do is you have to just remove that implant and renew the fixation with the long fixation implant to cover the fracture. If the implant's loose, you just add the revision arthroplasty too. Lately, there are algorithm of treatment. You'll be amazed when you see all of these. I will show you like in a flash. You see, there are so many possible scenarios that they suggest the treatment, and it's not possible to just show all of them for you today. But the principle is the same as I mentioned to you. If you're interested, you can just go on and read this by yourself. So the take-home message is, if the patient has stable implant, you can just fixation alone. If the implant is loose, you revision plus fixation. And the locking plate is an implant of choice. Try to overlap the plate enough to prevent the future fracture. And if you do it, and at the end of the case, you have short intermediate segment, don't forget to prophylaxis the future fracture. Thank you.